Hello, everyone, and welcome to the webinar, which is entitled #AskMeAnything, PharmD to PI, which is supported by the ACCP, Immunology and Transplantation PRN, as well as the American Society of Transplant Pharmacy Community of Practice. My name is Georgina Waldman. I'm currently a cardiothoracic transplant pharmacist at Massachusetts General Hospital, and it is my pleasure to be your moderator alongside Tara Veasey.
Hi everyone, I'm Tara Veasey, as you said, and I am a cardiac transplant pharmacist at Allegheny General Hospital in Pittsburgh, Pennsylvania.
Okay. A few housekeeping things before we get started. If at any point during the presentation you have a question for the speaker, please submit your question by using the chat functionality on the left-hand side of your screen and send the question to the presenter group. We will take questions at the completion of the presentation if we have time remaining. However, you all have submitted some excellent questions that will stimulate some great discussion as part of your registration. There will be an evaluation for this webinar available at its conclusion. Please, we encourage you to complete it and let us know how we did and things we can improve for our webinars going forward. We got a lot of great feedback from our industry one that helped us make this platform hopefully better for you all. The slides from today's presentation will be uploaded onto the ACC website under the section titled Webinar Slides after the presentation. And if you experience any technical difficulties during this webinar that are not fixed by logging out and refreshing your internet connection, please make the presenters aware through that presenter chat functionality. There's also a live chat in the upper right-hand corner of your screen where you can get live technical support from the AnyMeeting platform. Now, without any further ado, I will turn it over to our panelists for their introductions.
Hi, good afternoon, everybody. I'm Nicole Alvey. I'm Associate Professor of Clinical Sciences at Roosevelt College of Pharmacy in Schaumburg, Illinois. My clinical site is as a clinical pharmacy specialist in solid organ transplant at Rush University Medical Center in Chicago, Illinois. And I've been the PGY2 solid organ transplant residency director here at Rush since 2012. At the college, I'm responsible for delivering the didactic material to our pharmacy students, mostly concentrating in the renal course, but I also lecture on liver disease, obviously immunosuppression, and then therapeutic drug monitoring as well. I rotate through the inpatient and outpatient settings at Rush as part of my position as a clinical pharmacist here. What led me to this current position, my dad's a transplant patient. I was introduced to clinical pharmacy during his first transplantation when I met Karen Harniger as a member of his multidisciplinary team. And so I decided to pursue transplant pharmacy, and I've always had a passion for teaching. And so now my role as a faculty allows me to combine my two loves of transplant pharmacy and education. I'm so honored to be on this panel today. Thank you.
Hi, everybody. I'm Liz Cohen. Thank you so much for inviting me to be part of this panel today. My title is a Senior Transplant Data Administrator at Yale New Haven Hospital in New Haven, Connecticut. And my title doesn't really describe what I do, but basically I'm the project manager for the transplant team. So really I work on projects to assess and optimize outcomes in the workflow with that kind of quality improvement lens, but also working with other organizations for more of a clinical retrospective research to drive change. And I also work with different data portals within our institution. So I help our team determine if clinical questions are appropriate and help get some of that baseline information to start a research question. I got here, really, I loved transplant from pharmacy school, and I did my PGY1 and PGY2 and transplant here at Yale, and was an abdominal transplant pharmacist for 4 years before moving to my current role.
Thanks, Liz, and thanks everybody for joining us today. I'm Abbie Leino, and my current job title that I identify the most with is PhD candidate, though I have a couple of hats. I went to school at the University of Michigan, My current job description, I think, is the best job description ever. I get to do research all day, every day, and that's exactly what I wanted to do. So we'll talk a little bit later about how I got there. But after pharmacy school, I knew that I needed more clinical training, even though research was kind of always the end game. And so I did, your standard PGY1 and PGY2 in solid organ transplant. To get started on my research career, I then spent a couple of years at the University of Cincinnati, got a job as a clinical pharmacist, and then, really realized that there wasn't any time to be a scientist at the same time. And so circled back around to the PhD route to kind of make the time that I wanted for my research. And so hopefully we can help you today answer some of your questions about getting started in research.
Hi, everyone. Good afternoon. My name is Jamie Schulte, and I am one of 2 abdominal clinical specialists at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania. And here I rotate primarily inpatient and both outpatient with a focus on our interprofessional patient care. I work in our protocol development as well as get as much time doing clinical research as I can. And we'll talk a little bit about how to manage those things later on during this session. But as for my career path, I was previously at Northwestern Memorial Hospital as of last year as a part of a large transplant pharmacy team there, where I served as a resident research advisor and where I had completed both my PGY1 and PGY2. And I'm happy to be here today.
Hey everyone, thanks for inviting me to speak today, and thanks for being here. So Simon Tremblay, I'm currently the Associate Director of Regulatory and Scientific Affairs, which doesn't really tell you much about what I do, but sort of regulatory with FDA interactions and lots of science and protocol development and drug development at PTI Clinical Trials and Consulting Services, which is a contract research organization. So we run all sorts of things from trials to real world evidence, data management for clients. And really we kind of imagine the future of medicine, which is very, very cool because we're working on stuff that hopefully will change the practice of a bunch of fields, including transplant in the next coming years. So really exciting. And then how did I get here? I had a dean one time, which told me, your path is really convoluted. I'm not sure that's going to fit for us. I'm like, well, I guess we're not going to work together then. But basically it starts with a strong clinical background in practice. So I did my master's of pharmacy at the University of Montreal, then practiced for a few years in all sorts of settings, hospital, inpatient, outpatient, and heart transplant. Then went to Vancouver to do a postgraduate PharmD there, where I did some lung, liver transplants as well, and some more heart, before coming to Cincinnati to do a traditional PGY2 and a fellowship in clinical research afterwards, where I stayed on as a research associate and then stayed on as a assistant research professor of surgery, so on faculty there for a few years before I made the move to the CRO industry to do research for big clients. So hope we can answer a lot of your questions today.
Great. Thank you all for your wonderful introductions, and we're going to dive right in. For our first question, this is actually going to be addressed to all panelists, starting with Jamie. And this one was a common theme we saw throughout our responding questions, so we figured we'd get everybody's perspective on it. Can you describe how research is incorporated into your daily practice, giving us a sense of your clinical versus research time percentage, as well as what projects you're working on with your current role? Jamie, we'll start with you.
So as I mentioned, my role is primarily clinical in nature, and it's focused on immediate patient care. So my experience with research is really adjunctive to my day-to-day responsibilities. Involvement in scholarly activities is part of our clinical practice model here. So I'd say I'm generally about 90% clinical, with 10% of my time focused on research. However, I'm sure, as many of you can attest to, that really that breakdown is very much in flux depending on how busy the transplant service is, which of late has been very busy. So that can vary from day to day. And as for the type of projects that I work on, I currently focus on research that is retrospective in nature and related to practices embedded within our current transplant processes.
Wonderful, thank you. And Nicole? Nicole, I don't think we're able to hear you. Are you still on mute?
Can you hear me now? I'm having all sorts of technical difficulties right now. My screen keeps freezing, my video keeps going out. Okay, so how I incorporate research into my, like what my percentage of clinical practice is research. So most of my research is done through our PGY2 residents. So I'm always the mentor for their residency project every year. In addition to, they are assigned a quality project as well too. So I incorporate I try to mesh my role as the RPD into my research role so I can kind of kill two birds with one stone, if you will. And then also as a faculty member at the College of Pharmacy, I've started to do some research in academics. And so teaching strategies, how to best teach for different learning styles and things like that. And that's been an interesting avenue, not transplant related, that I have become involved in. And interestingly, it's overlapped to our transplant patients because just like every student has a different way of learning, every patient has a different way of learning. And so now trying to incorporate, again, my research in academia and translating it over to our transplant patients and how they learn has been really, really rewarding. It is difficult to fit it in, just like Jamie had mentioned, and I think pretty much everybody will mention as well too, but I found that if you can, like I said, multitask and kill two birds with one stone. So can you wear your RPD hat and do some research? And can you wear your professor hat and do some research at the same time? And so I try to find some overlapping areas in which I can dabble in research while still being able to do my quote unquote daily activities.
Wonderful. That's definitely a theme of the presentation. And Liz?
Yeah, so because I have this new role, I was able to negotiate that I spend 2 days a month on the clinical service as the pharmacist. So in my normal day-to-day role, I do spend most of my time really doing project management and really to get projects moving along. Some of that's like building reports, working on optimization, for example, with our EMR. I spend probably 25 to 50% of my time actually doing the research. So reviewing, analyzing data, answering questions, writing papers, analysis, etc. In terms of some of the current projects I'm working on, I do have an investigator-initiated study assessing memory pre- and post-conversion to Envarsus and kidney transplant recipients. We're also working on totally revamping our living donor intake and education, and we want to analyze what that means in terms of numbers of living donors. We're also looking at things like aligning non-HLA markers with clinical outcomes. So another kind of big project that I'm working on, and also a lot of other living donor things like looking at rates of non-alcoholic fatty liver disease and potential living kidney donors. So kind of a little bit of everything as different teams request it.
Awesome, very interesting. And Abbie, can you tell us a little bit about your roles?
Sure. So I think my role right now is a little bit different since I'm currently a student, but I think it lines up decently well with what it'll be like as a kind of a tenure track faculty, which is where I'm hoping to approach in the next couple of years. And so while I initially said 100% research, it probably doesn't end up actually being that, because with teaching responsibilities, and I volunteered to help in the clinic, so I'm doing a day a week in the clinic right now. So I would say probably ends up being 75-80% research, which I think is much better than I was getting before and closer to where I'm hoping to end up. And so that allows me to have my hands in lots of different pots. My PhD advisor is really into precision dosing and PK/PD modeling, so that'll be a lot of what I work on, applying that sort of processes and techniques to transplant patients. But the other aspect of it that I think is also super important is if our patients don't take their medications, it doesn't matter what we've modeled from a PK/PD perspective. And so how can we incorporate knowledge about medication adherence into those types of assessments as well is another piece of my research.
Very interesting. And then Simon?
Yeah, so I guess I had the full-time investigator faculty role where I was about 90% research, 20% clinical, and 20% everything else. So that does add up to more than 100%, which is always hard to manage. But now in my new role, I don't have any of my own personal research. I really have two main roles. One is, from a clinical standpoint, a lot of mentorship to junior scientific writers and team members, and really bringing clinical perspective to clients to kind of support our medical affairs team. And from a scientific standpoint, there's really two types of science that we do. One is regulatory science, where interactions with FDA, Health Canada, EMA, and other regulators, which is very fascinating. So a lot of training from that perspective, and starting to share our experience at different regulatory meetings and so on. So kind of like a transplant meeting, like kind of ASD, but for regulatory professionals. So that's kind of exciting. And a lot of applying our clinical knowledge as pharmacists, our skills to develop protocols and answer questions. Also collaborate with some of our colleagues in real world evidence, doing a lot of retrospective data and database analyses on their end. And even dabbling into some business research and kind of market ideas. So that's kind of what my mix is.
Yeah, no, definitely something that we may not have all interacted with. So for our next question, we're going to kind of focus on that residency preparation. And to start with you, Jamie, so what skills would you recommend residents acquire during residency to prepare for a future career in research?
So since I'm probably the closest to my residency out of this wonderfully experienced panel, this question kind of was near and dear to my heart. And while I think there's a lot of really great skills that are important to building the backbone for research in your career that you're going to learn as a resident, thankfully, a lot of those are built into some type of residency curriculum. And I think a lot of those are intangible things that you need to think about as building your skill set. And so things like good time management and attention to detail are very valuable. One particular skill that's something that can be learned while a resident, I think it's really important to be able to create an effective data collection tool. And I've probably learned the hard way too many times with this one, but I think it's really important to be intentional with how you plan to collect your data and how you eventually do collect your data. It can save you a lot of headaches and time down the road. And I think that learning how to identify data that is meaningful and accurate and best suited for the end purpose that you're actually working towards can really help you go beyond just recording your events and actually creating context for your research.
Great perspective. And from the RPD perspective, Nicole, do you mind telling us, giving some insight on the skills you recommend residents acquire?
Sure. So I definitely echo what Jamie said in terms of learning how to best collect the data. I think the big thing that we focus on, especially during the first couple of months of the residency, is just learning how to formulate a good research question. And then that helps you guide how exactly you're going to go about collecting your data. And formulating a good research question takes in, it's not just the question itself, but who are you, who can you collaborate with? What sort of impact is this going to have, not only for your institution, but for the transplant community as a whole? And to be okay with the fact that it's not going to go flawlessly, that a lot of the skills learned during residency come from mistakes, challenges, mishaps that you may encounter. So as Jamie said, learning the hard way one too many times, but that's how she learned, right? And that's the most important thing that I think is the struggle for the residents for the first couple of months is you're a resident, you want to come in, you want to change the world. And it's really getting the resident to understand that you can do that by not asking this, large, broad research question, that we can take things one step at a time. And really make a big impact. And it starts with your center, and then that, goes out onto other transplant centers as well. So I think that's important for the residents to keep in mind.
Yeah, and I think that's a great transition into our next question, which is, what are some of the biggest barriers you've seen to resident research projects reaching that publication, that last step? And Nicole, we're going to go back to you from the RPD perspective.
Sure. So the biggest barrier, as probably everyone will admit to, is time. Because suddenly, it's November and you're submitting your ATC abstract and you think, oh, I have all the time in the world now to get this project done. I've got the abstract in. And then suddenly the residency is over. And then you think, oh, but I've got this, month off that I've taken off in between, my residency and starting, my job. So I'll finish my manuscript then. And, then suddenly it's a year post residency and we're still working on the manuscript. And it's not just on the resident either, it's on the RPD as well, because we kind of have those false senses of security too. So I think that's probably the biggest hurdle in getting the publication, because there's always somewhere to publish, right? No, it may not be AJT, but there's always somewhere to publish. And so one of the things that we started doing, which we should have been doing for a long time, was having the residents select the journal so that as they write their manuscript, it's in that particular format. So at least that way we've got something, we can submit it for publication. And I think the resident being aware that you're not going to submit for publication, it's going to be accepted, that there's going to be multiple submissions to potentially multiple journals. And that can also be, obviously a barrier to getting the research published.
Certainly can be. And Liz, do you have any other thoughts on the barriers to research publication?
Yeah. I think every year as an RPD, I get a little bit better at this, and Nicole can probably speak to that too. You learn so much as you go, and I can tell you that it kind of gets better and better as an RPD and what we can teach our residents. But really, just to echo Nicole, persistence is key. I can tell you that my resident 3 years ago, we just got her research published. And that doesn't mean that it wasn't good research, but it meant that we had to go through a couple journals and rounds of edits and kind of really just being persistent. And really just setting up that research question and understanding what data to collect and how to analyze it, and then just being really consistent. I think the other barrier to publishing, I would say, is cost, right? So a lot of the journals where it may be more likely to be accepted might be open access, or there might be a fee associated with it. So I think we've, at least, my group, we've been a little bit better at partnering with providers who might have, a little bit of money that they can use to be able to get it published, which I do think is another barrier. But truly just persistence on the resident, even after residency, and persistence on the RPD. We've also done a good job, I think, identifying that sometimes the longitudinal research project isn't the project that needs to be published. Sometimes it is that quality improvement project or cost analysis project. And sometimes those are done earlier in the year, and we can just get that kind of trucking along rather than waiting for that longitudinal research project. So I think just also awareness of what's worth publishing and maybe what can you feasibly get done.
That's some really great insight of, it might not be the project that you think that is going to make it to publication, or it might not look the same way when you were designing it. Jamie, can you tell us what some advice you have for new practitioners that are trying to do research while in a clinical position, such as yourself?
Yeah, so as a relatively new practitioner myself, and actually a new team member at my current role, I definitely understand how it can be a little challenging to carve out time specifically for research. I think Nicole already touched on this a bit, but I think collaboration really can be one of your biggest assets as you're first getting started. There's a lot of opportunities for formal collaboration if you look for them with students or PGY1s or PGY2s. And that could give you an opportunity to maximize your time as a clinician while still being a part of research as you're building your own clinical services or really focusing your time on how to integrate yourself into the team. And even if you're not able to work with a resident on a project, you can always consider using their fresh eyes as a way to identify research ideas. That's something I found really useful. I'll ask each one of my residents who takes the rotation to try and identify something that they would be interested in reading about or be interested in researching about. Maybe something that I hadn't thought of just because I've seen it day and day and day again. And so I found that to be an interesting avenue. And I've also found that research opportunities can usually be found when working closely with other members of the healthcare team, as Nicole has mentioned as well. So I recommend as you get started, reach out to the APNs that you work with and the fellows and the physicians and the nurses that you work with. Chances are they are most certainly just as busy as you are, and they would probably welcome an opportunity to collaborate on a research endeavor.
Great, yeah, some great advice, especially the fresh eyes perspective. I definitely find that in our practice as well. It's very helpful. So now we're going to talk about that practitioners who have transitioned away from clinical practice. So Liz, hoping you can start us off here. At what point did you make the decision to transition away from your clinical practice, and what were some drivers behind that transition?
Yeah. So for me as a pharmacist, I would sit in like these project meetings led by maybe a physician, and I felt like the projects would just drag on and on. And I think just naturally as pharmacists, we do a good job of actually moving projects along. But I was finding that I would want to move projects along that maybe didn't have anything to do with medications, or it was maybe outside my scope per se. And so when this position became open, it had always been previously been filled by a nurse. And so when I sat down with a clinical director and talked about the role and what I was looking for, just kind of more of that project management, they were really willing to work with me. They already knew me as a team member. And so I think just really noticing that opportunity to kind of transition to the full transplant team, and then was what kind of triggered me to be comfortable to move out of my clinical position.
Great, yeah. And Abbie, can you tell us a little bit about what made you go back to your PhD?
Sure. So I think kind of at every step, every decision point kind of along the way, it was always all right, so what am I going to do now? When is going to be my time for research, and when am I going to head down that path? I think probably if you asked my mentors here at the University of Michigan if they're surprised that I'm back to get my PhD, everyone would say, no, we predicted this 10 years ago that you would be back here. But I think to me, it was very important to get those clinical skills, that clinical background, to be able to practice as a pharmacist and really know what are the problems for our patients, what do we need to fix, what do we need to solve. And so for me, it was when my list of ideas of what I wanted to study far exceeded the amount of time I had to put into it. And that was like, all right, I have enough problems to solve. I can get started on my research career now. And I want to do it now. I don't want to wait. They kept saying, oh, we'll make a faculty spot. You'll eventually get your research time. And the number just kept getting longer and longer in the future. And I was like, no, I'm going to do it now. And so the nice thing about the PhD is it allowed me to just go from 100% clinical to 100% research overnight, rather than taking a bunch of small steps in that direction over time. And for me, that was what I was looking for.
Great. Thanks for that insight. And Simon, can you give some perspective on how far along in your clinical career is the right time to transition to full-time research?
Yeah, I think that's a tricky one. In my case, it was partially opportunity. If you asked my classmates in the pharmacy school if I would even get into residency, they would have said no. So as you mature, as you build your team, your collaborations, you get to see around you if you have a team that's ready to help you out and you can help the team, right? Is there a need where you are? And if not, find a team that could be receptive. Because as been mentioned before, you can't do it all alone. It's impossible, right? So for me, it was I love clinical practice, and I just felt like seeing patients in patient or clinic, it was amazing. It was great. Then I could help patients on a larger scale if I kind of took off my clinical hat and put my research hat on and said, well, how can I address this? And I was fortunate to be in a very, very generous environment that allowed me to really thrive as part of the team. And then my decision to go to CRO was also motivated by the fact that I said, well, it's great to do my own research, right? But how can I impact patients on a larger scale, not on just one project, but on, 15, 25 projects at once.
Yeah, thank you for that. The next few questions that we have are actually all about the additional training that you may or may not need, or how much you need for research. So coming back to Simon again, how much experience would you say is needed to become a PI?
Sorry about that. I pressed something on my phone, did not go well. I think, one, you need mentors, right? Whether they're pharmacists, physicians, nurses, or anyone around you, you need mentors. They don't have to be at your institution either, right? Find your mentors throughout your career. Start small. That's been mentioned before, right? But when I did my PhD, my advisor said, Simon, don't change the world. Get your degree, right? Start small, be successful, right? Show a track record of success with small projects, right? On retrospective trials, for instance, you're a PI on that. You don't have to jump to full-scale 500-patient randomized controlled trial. That is not a path for success, especially not on your own. So start small, build your team, build relationships, get extramural funding for some of these projects as well, right? So you show that you can do retrospective unfunded things. Get some intro or extramural funding, even if it's $1,000, right? It looks great and you've accomplished it. And as you build this, you build your name, your team, but also your confidence. And I would never have been PI on anything without having my mentors around me, especially for the first few times, because that is just very, very scary. So always have a strong team around you and mentorship and accomplishing, show a track record of success.
Yeah, that's great. I think mentorship is so important for so many things. So I think that's excellent to mention. For our next question, we'll go to Abbie. And what would you say are the benefits of formalized education in research?
So I think it all comes down to that research is a spectrum. What do you want to do? Do you want to be doing, retrospective studies, kind of evaluating your own patients and trying to figure out how can we make things better at our institution? Do you want to be doing something prospectively and maybe it's just observational? Or do you want to be intervening on these patients? Do you want to be doing drug studies? What do you want to be doing? Some of it's a lot easier to do without formalized training. And like Simon said, those sorts of things you can find a mentor at your institution. Maybe they're not even in transplant, but maybe your ICU pharmacist is really great at getting things published and would be willing to work with you on something to get you some of the basic skills of navigating. How do you do that at this new institution that you're at, at your first job or something like that? Maybe you want to do more complicated statistics. And so maybe a course or two at a local university might help you get to where you want to do that. For me, I wanted to do more basic translational stuff. I'm learning how to use the HPLC this week. That was not something I was going to be able to do on my own, right? So I needed the additional formal education. And I think it also helps from thinking about the theory and the methodology. There's a lot more out there than that you can cover in residency programs or in pharmacy school. So if you want to really get specific on something, there's probably a lot more out there. And for me, I am an auditory learner, so hearing somebody talk to me about it, I get a lot more out of it than reading the paper. So, maybe you can read a textbook and that's all you need to do. But for me, the formalized training is an important part of the way I learn and process information. And so that's part of what has driven me to go the more formalized route through all of this.
Yeah, that makes a lot of sense. It's going to depend on exactly what it is you're looking for and how formal you need to be. And so with that more formal education, Simon, how does that help you transition from retrospective clinical projects to larger prospective studies?
Well, I think you need to get the right thing for your needs, right? I would say get exposed to a lot of things up front, even if it's just accompanying your research coordinators for consents, right? For things that seem trivial, but showing you the day-to-day activities, right? If you want to do something like real-world evidence, database mining, big data, these are all very, very different training programs you need to. But I think if you want to do a move ahead with clinical research, have a strong clinical background. You need that to answer a question, right? That's essential. To have courses in trial design, it doesn't need to be a PhD level degree. There's multiple certificates and other degrees where you reinforce what you already know about clinical trial design through your practice writing with feedback. And then run your ideas by some of your team and mentors and see how you can get that funded. But you really need to know what your strengths and limitations are, what your team needs as well, and kind of go in that direction, tailor it. There's no one size fits all, unfortunately.
Sure, for sure. So our next few questions are more for the people balancing with some clinical and some research time. So the next question is, how do you balance research with the clinical role and approach discussions with administration about research dedicated time? And we'll go to Liz first with this one.
I'm going to start with that this was not a popular question to answer. So I'm going to say, I'm going to start with that. It's hard because I would say when I was in a full-time clinical role, I wasn't so much balancing research with that clinical role. I was doing research on top of my clinical role, right? And so, but I was really fortunate when I was in that clinical role that my manager was a former transplant pharmacist. So Eric Tishy was my manager. And so when I received a small research grant, I was able to go to Eric and say, hey, I got this small grant. I really do need some time set aside to do research. And so at that point, we were able to work together, and I was able to get a few dedicated like project days a month to dedicate to that research project. But I would say that I did have to, kind of push it with hey, I got this grant. Like I need a little bit of time so that I can actually complete this grant. But I do think it's tough, and I do think that most people in a full clinical role would say that research is on top of their clinical role.
Yeah, Abbie, do you have anything to add to that? I think you're muted.
I thought I got it unmuted. So I'm answering this question as the person who failed to be able to balance clinical and research. And this was kind of something that we started talking about when I first was looking at the job. They know I did a research fellowship, and that research was something that I wanted to do and be part of my career. And so I was like, okay, great, yeah. But I think the one thing to know is it happens way slower than anybody is ever willing to admit to you. And I think you have to be willing to either be patient, which I was not, and be very persistent. And I think Liz makes a really good point that it's going to have to be probably on your own time at first, if it's something you really want to make happen, to kind of prove and demonstrate that, yes, I've been successful. I've pushed something the whole way through. I've gotten this first grant. I'd really like to write something bigger. Now I've done it, and that's usually how you can work your way into it. But for larger chunks of time, beyond a few days, you're probably going to have to think carefully about the position you're in and whether you need to make a move to something like more of a faculty position where they have a slightly better balance between clinical and other responsibilities, where they want a little bit more research out of you, or write a big grant that's going to fund a portion of your salary, if you really want to be spending more than 10% of your time in research.
And that'll transition us to those that have more of a clinical role and less of that dedicated time. So how do you balance research with a clinical role if you don't have any dedicated time? And what advice do you have for consistently integrating research into your day-to-day activities? And we'll go to Nicole first with this.
Yeah, so I'm really sorry if all of you have tuned into this webinar for 40 minutes thinking that once we got here, we were going to give you the secret to how to balance research with a busy clinical career. But unfortunately, I'm very sorry, but I don't think any of us have that answer. I know we've heard it time and time again that to get started, you're going to have to invest a lot of your own free time, because you have to, like everybody has said, you really have to prove yourself first before given the time to have dedicated time to research. I think I mentioned earlier that I do try to overlap the clinical practice with the research questions. So keeping your eyes and ears open when you are on rounds, when you are in the clinic, is there a research question here? Is there research that I can do while I'm seeing a patient in clinic? So one of the things I'm really interested in doing coming up is surveying patients about their knowledge of the importance of medications pre-transplant, and then surveying them after we do, some more rigorous education at their initial visit and see if those opinions have changed. That's research, but that's also me doing what I'm going to do every single day anyway and seeing the patients in clinic. So are there research questions that you can ask that you can gather that data while you're performing your daily activities? So I think for me, that's really been the key in integrating it into my daily practice.
Yeah, for sure. Jamie, do you have anything to add on that one?
Well, I think Nicole, Abbie, and Liz really all hit the nail on the head with that. I think balance is really an ideal world for all of us. So I think it's certainly very difficult to do if you don't have any dedicated time. But if you're passionate about it and you really want to make it part of your practice, you just have to find the time to do it. And whether that means kind of always chiseling away, even if it's very slowly over time, even if it's 3 years since the time you were a resident to the time of your publication, just, really continuing to strive for it. I too do some of the tricks that Nicole mentioned. I always am looking for gaps in policies or processes that are in my day-to-day that I can turn into research ideas. I actually keep a running list on my phone so that if I'm out, I always have my phone with me. I can just jot it down. And even if it's a very limited concept that maybe I could flush it out later, it's something that was in my mind at that point in time that I can reflect back on. And then I also find that staying connected to new literature actually really helps fuel my passion for research. So that, again, kind of hits two birds with one stone. Staying on top of new things that are coming out always helps me to want to do more of those things myself. And I've always found that being a good reader actually translates to being a good writer. And so staying on top of that new data is not only helping my clinical practice, but also eventually helping my writing skills.
Yeah, that's a good point as well. So we've mentioned a few times collaborating. So the next question is, what physician/provider collaboration models are recommended for delegating trial-related medical decisions? And this is going to Simon first.
Yeah, patient safety first, right? That's always what you have to have in mind. And depending on the type of trials you do, you need to consider the schedule and the timeline, right? So have a good coverage. I was working in a very PharmD heavy system with a lot of medical support, and there's nothing wrong with having additional investigators on board, right? Whether it's the PI or other investigators, nephrologists, hepatologists, or whoever other physicians you work with, but just having someone you can run things by. The relationship between clinicians is very different inside a research project, I find, versus outside, right? Because it's all about patient safety and the outcome, but also on the protocol. So ultimately, though, everything is the responsibility of the PI, but as a non-physician, right, things cannot be delegated to you, so you need to delegate and discuss. But I think having regular meetings with your research team as well to discuss patients is also important, because you come to shared decision making together. So you share their experience and they see yours and the investigator as well, which I think is great. And then so I would say, especially in transplant, having a surgeon and an AAA physician, at least one on your team, and discussing these patients is very important.
Sure. And to get, I guess, a different kind of perspective on that collaboration model, we were going to go to Nicole with this question as well.
Yeah, so one of the things, going back to the previous question of how you integrate it with your day-to-day activities, is collaboration's a big part of that as well too. You don't have to do it all on your own. You can't do it all on your own. These are transplant patients, and they're patients of a multidisciplinary team. So in order to do research and make change, everyone on the multi-D team has to be involved. So I think reminding your physicians, your nurses, your mid-levels about why you are wanting to do this research and how it can benefit your patients, and then also how it can benefit them. Most surgeons and physicians need research and publications in order to be promoted within their colleges and things like that too. So this isn't like they're doing you a favor by being on this research project. And if that is the attitude, try to turn that a little bit, because it is of benefit to them and their patients to be involved in these studies. And so engage them, ask them what research questions they've been dying to figure out. They probably have a list as well too that they carry around, just like Jamie does. And so I think ask them, and we do that every year before we do our residency projects. We ask our surgeons, what sort of research ideas are you guys thinking about that maybe a pharmacy resident could help with? Because just like us, they're very busy too, and they need collaboration in order to get their research done. So it's a win-win situation, and if you take it from that perspective, I think it makes a big difference.
Yeah, I think so too. I think as they see what you can do and what you and your residents can help, then I think they'll come to you with more, for sure. We've heard a few comments about grants and things along that nature. So our next question is, what are some avenues for research funding? And we'll go to Simon with this one.
I can answer in a very, very, very short answer. It sucks. It's difficult, and you'll get at least, like publishing is hard, right? Getting grants, I find, is crazy harder. But long story short, again, your team, your mentorship, right? Who's on your team has an impact on the grants. It always does. And then their experience in helping you grant writing, which is very different than just writing a paper. It's very, very, very different. Look internally. Most health systems have a lot of internal grants, right? And people say, well, $1,000 is not a lot. Well, it's a grant. It's still a grant, right? And when you go to apply for a new grant, hey, you've got a grant already. So you've demonstrated that. Publish your things that you do with your grants, very important. And start small. You have intramural. A lot of things are intramurals within your system, which can really, really help you. And it looks really good for outside. And then most hospitals also have grants officers or people that are specialized in just finding funding opportunities. So sit down with them early. Talk about your career plan. If there are a lot of grants for junior investigators, for instance, that are you're only eligible for a few years. There's KL1. There's all these other types of grants. So look at people who are not that much older than you, what they've done, how they've gotten there. Look at inside your own hospital, which is often easier to get, and get your mentors help you out, but also talk to the grants people in your centers. So they can tell you so much about all the grants available.
Sure. And then we also wanted to see if you had anything to add about that, Liz, as well.
Yeah, so I've applied for multiple grants, sometimes with success, but more often than not, kind of like Simon was alluding to. There's lots of grants inside institutions. There's also small grants, pharmacy organizations, transplant organizations, but also looking like outside the box. Like, for example, the American Diabetes Association likes to do research in maybe transplant. So that's something that you're looking at. I've always partnered with physicians who have relationships with those societies, because as Simon mentioned, it's who else is on that grant too, especially if you're just starting out. And I got my first grant as a co-PI for an investigator-initiated study. And so another thing that I've learned is, if you can at your institution, talking to pharma companies, seeing what they're interested in, gauging their interest in different studies, different things that you can do at your institution. There's lots of different places money can come from, not just the ones that we typically think about.
Thank you. So we have one last official question that will be for all of the panelists, but I also wanted to remind everyone in the audience, if you have additional questions, please do type those into the chat, and we can take those at the end as well, since it looks like we may have a little bit of time left. So for all of the panelists, we would like to know what quote-unquote pharmacy skills do you bring to your research career? And we'll start with Simon and then kind of move through the rest of the group.
Yeah, I think thinking of it the reverse way as well in my mind, right, is what pharmacy skills do you already have that you don't even realize apply to research, right? Think back into pharmacy school, all those phase 1, phase 2, phase 3 trials, and we all went, oh, whatever, who cares, right? You never thought you'd be researchers. Some of us, well, I did not, but I'm sure some of you did, right? But all that clinical trial, all those epidemiology courses that, bias, confounders, relative risk, odds ratios, you've learned all that. And we spend a lot of time doing that. Every time you look at a paper, right, you analyze literature, you're using all those skills that I know I didn't even think, I was doing already, but I didn't realize how valuable they could be, right? And that's already a big leg up. So don't forget that, and utilize those skills. Don't think that because someone's a different profession or has a PhD that they're necessarily well versed in those concepts, which are crazy important for clinical research. That was kind of the big thing, and others have great answers, I'm sure, but that's kind of what I wanted to bring. Just don't forget about your own background, which I think we forget about too often.
Yeah, maybe Abbie, do you have anything you could add to that?
Sure. So I think what really comes to my mind is, as the pharmacist on the team, you know what the problems are. A good research question starts with something somebody's going to care about, right? Like you could think it's the most interesting thing in the world, but if nobody else cares about it, you're not going to get it funded and you're not going to get it published. So you have to know what the problems are that the community cares about. And so as a practicing pharmacist, you are kind of in the hot seat. You know what's going on. You know what things need to be addressed. And you have this great group of pharmacists out there who provide you with webinars to give you new knowledge and things like that. But you can build on those relationships as well and use them to inform your future projects and things like that.
Thanks. And we'll see what you have to add, Liz.
Yeah, I think the biggest thing when it comes to research is that I think most of us are probably type A personality. And so that's what good research requires. But I think it's also, you are a good writer, you probably just don't know it. Think about all the journal articles you read and the journal clubs you do and critiquing articles and how hard you are on the authors. And so just think about how probably good you are at writing, even if you haven't tried it. And so I think that kind of just the personality of being a pharmacist lends it really well to research and writing and presenting our research. So just recognize that you're probably better at it, even if you haven't done it, that you'll probably be successful.
And then we'll see what you have to say, Nicole.
So I think one of the skills that we have as pharmacists is, I'm going to say it's our sneakiness. I don't know if that's really the right way to put it, but, in twisting something that you really want or really believe in and selling it to your team or maybe some of your physicians as, their idea, and suddenly it takes on a different perspective. And so that's kind of how I approach, our research questions too. And I just use, a prospective study that we're doing here, looking at albumin with Lasix versus Lasix alone for diuresis in cirrhotic patients. It was one of the things that our physicians absolutely insist is necessary to do. And so we, said, okay, fine, let's do a study on it. Let's put our money where our mouth is, and, kind of engaged our physicians in that way. And so use your sneakiness, I guess, as a pharmacist to engage your physicians into, not that they don't want to be involved, but like I said, helping them see how important the research is to their patients and to themselves in their own career as well.
Yeah, I like that sneakiness. And then we'll take you last, Jamie, for this question, and then we'll look at some audience questions.
That really resonated with me as well, Nicole, as did everyone else's answers. But I think one other thing that we have in our arsenal is that as pharmacists, we are really judicious with resources. Our patients have challenges with obtaining their medications, or we have restrictions in formulary, or we have cost restrictions. And those that judiciousness of us as pharmacists, I think, really can help us drive home questions that we want to answer to help us maintain that ability to use limited resources in an appropriate capacity. And so I think we always have to think about that from a pharmacist's eye as well.
Great. Thank you all for that incredible insight. We do have a new audience question, and we'll start with Liz. As a preceptor, how do you decide if a research idea is appropriate to be led by a student, a resident, or if it requires a clinical pharmacist perspective?
Yeah, that's a great question. So we offer a lot of opportunities for students to present a lot, especially at mid-year. And we really take the question and decide on the scope. Can they realistically do it within a couple weeks, a couple months, or is it longer than that? And that really helps us really decide if it's an appropriate question. Also taking into account like what data needs to be maybe pulled out of the electronic medical record. Is it something that's really straightforward, something that a student can identify, things like lab values? If it requires a lot of chart digging, like reading actual notes and clinical interpretation, that might be more appropriate for a resident or a preceptor. But I think it's really for me, it's the time and the scope.
great. That's a great insight. And Abbie, do you have any other thoughts?
So I think for me, it starts with the time. What do I have time to do? And what do the students or the residents have time to do as well? I feel like sometimes students have a little bit longer duration. They're going to be around for a while. So maybe it's something that they can do. It's a maybe it's a prospective observational type thing that they're able to help you collect data for because they're going to be around for the next year or two. I think, but students can be tricky. And so how much time do you have to train that student to do it accurately, to get you the information you need at a quality level that you're going to be able to publish, garbage in, garbage out. So do you trust the student? Do you have the time to train them? Something that I found to be really useful is you have to put a lot of time up front into the students, and then usually 2 students, and then you can use things like REDCap and do double data collection. So if the values don't match, you need to adjudicate that to make sure that you end up with accurate data from a student. Whereas a resident has potentially done a little bit of research before, particularly if we're talking about our PGY2, they at least did something as a PGY1, and maybe they don't need that sit-down lecture on how do you data collect and how do you decide, if you have multiple pieces of data, how do you pick the source of truth, and how do you put together a data dictionary that helps guide you. And then I think at some point, you always put the student and the resident first. And so if you've got a project and someone who's looking for a project, you put them ahead of you to help advance their career. Like I've got a project right now I'm really excited about, but I have a student that wants to do it for their research project. So I'm like, sure, here, you can do this. Because it helps me out, but it also helps them learn about this process of research.
Okay, I think we have time for one last audience question if we do it pretty quickly. So this one is, working with the multidisciplinary team is a great recommendation, but sometimes authorship can be tricky. What tips do you have, and how is position that important as a PharmD? So we'll get a quick answer from Nicole and then also Simon on this one.
My answer will be very quick, and it's just that it needs to be addressed at the onset of the project. It has to be addressed from moment one. And then if something were to occur where someone's not pulling their weight and say they're first or last author, then it needs to be addressed at that given time. But in my experience, authorship has to be something that's addressed before anything else is addressed in the project. But I am interested to hear what others' thoughts are.
Nicole, completely agree. And as you mentioned, right, a lot of people need to get promoted, and it's very tempting to be on things and not do much. And it's really frustrating for the people doing the brunt of the work, right? So this thing up front, it's, it's like, money discussions. No one likes having them, but start right off the bat and discuss tasks and what people are going to do. And I think that's something that the residents or the trainees should not necessarily have to be doing themselves, or should never do themselves for sure, and may or may not be involved at all, because it's that kind of a faculty level interaction out of respect for faculty, but also for students. And I would recommend that everyone goes back and reads the ICGME guidelines on authorship, because people often don't think about that or don't realize that there are guidelines as to what it means to just be an author, right? Versus an acknowledgement. There's even that, not just order of authorship, but also who gets on the paper, and be aware of that. And then if people really contribute equally to the paper, well, there's a way to say that, well, those people contributed equally to the paper as well, right? And there's a kind of a happy medium. But of course, we only cite the first author name, so that's always what people want to get. But I think, as Nicole said, discuss it upfront and have no shame in discussing it, because it prevents so many problems down the line. And you may have to rework your entire research team depending on how this goes, right?
Well, thank you, everyone. I think we had a lot of great discussion. I really appreciated learning all of your perspectives, and thank you so much for your time.
Thank you.
Thanks for being here.